Welcome to this clinical simulation explainer. We're skipping the basics today and jumping straight into a rigorous peer-to-peer review of high-stakes metabolic emergencies. Our target? Flawless 270-plus level clinical execution. We are going to dissect the exact mechanisms, discrete management steps, and diagnostic traps surrounding life-threatening electrolyte derangements. So let's get right into it.
Module 1, Hyponatremia Correction and Osmotic Shifts.
Our immediate focus here is the profoundly dangerous neurological consequence of improper sodium correction. Hyponatremia isn't just some laboratory number on a chart. It represents a highly volatile fluid shift across the blood-brain barrier. To really understand the stakes, we have to look at the underlying physiological mechanism. In chronic hypoosmolar states, the extracellular fluid is excessively dilute. Left to its own devices, water would just rush into the relatively hypertonic brain cells, causing lethal cerebral edema. But the brain is remarkably adaptive. Over about 48 hours, those neurons maintain their volume by actively shedding intracellular osmoles, like potassium and organic solutes. This successfully equalizes the osmotic gradient and stops the brain from swelling, but it leaves those exact same neurons incredibly vulnerable to any sudden changes in serum tonicity. And ignoring that vulnerability, well, that results in iatrogenic catastrophe. Just take a look at this MRI demonstrating osmotic demyelination syndrome, historically known as central pontine myelinolysis. When we rapidly administer hypertonic saline to a chronically adapted patient, it creates a massive osmotic gradient. That gradient pulls water entirely out of those adapted neurons. The cells instantly shrink, which physically shears the myelin sheaths, predominantly right in the pons. Tragically, this presents Ds later as irreversible quadriplegia, dysarthria, and the devastating locked-in syndrome. So here is your high-yield absolute rule. Once a patient's symptoms improve, you absolutely must not correct sodium faster than 8 milliequivalents per liter over a 24-hour period. This strict clinical threshold is literally the only barrier between your intervention and a severe demyelinating injury. Now, this clinical variance box sharply contrasts these discrete complications. It's fascinating. If you correct hyponatremia too rapidly, you pull water out of adapted neurons and you cause osmotic demyelination. Conversely, if you correct hypernatremia too rapidly with hypotonic fluids, you drive water into adapted neurons, causing catastrophic cerebral edema and brainstem herniation. These are identical rapid interventions yielding highly divergent, fatal outcomes, all depending entirely on the patient's initial metabolic baseline. Okay, let's test this with an integrated assessment. You've got a patient with severe chronic hyponatremia. Their sodium is sitting at 112, and they are actively seizing. You need an immediate, precise intervention. What is the exact pharmacological management required? Let's systematically break down these 5 answer choices. Choice A, 0.9% normal saline is completely insufficient to arrest an acute metabolic seizure. Choice B, strict fluid restriction, is a fine baseline treatment for asymptomatic patients, but it's totally inappropriate as monotherapy for active seizures. Choice C, an aggressive 3% hypertonic saline bolus exceeding the daily limit will definitely stop the seizure, but it absolutely guarantees osmotic demyelination days later. Choice D, desmopressin, actually worsens the hypotonicity and drives the sodium even lower. That leaves us definitively with choice E, targeted 3% hypertonic saline. You administer an immediate targeted correction solely to stop the acute seizures while rigorously respecting that 8 milliequivalent daily ceiling.
Moving right along to Module 2, SIADH versus cerebral salt wasting.
We're going to start with the CNS pathway trap. Following a severe CNS insult, like a subarachnoid hemorrhage, you'll frequently encounter a patient with true hypotonic hyponatremia and an inappropriately high urine sodium, often greater than 40 milliequivalents per liter. The trap here is that both the syndrome of inappropriate antidiuretic hormone, or SIADH, and cerebral salt wasting, or CSW, present with these exact identical laboratory values.
So, how do we differentiate them? This diagnostic decision matrix clearly isolates the physiological drivers, and getting this distinction right literally dictates survival. In SIADH, inappropriate ADH release expands total body water, which renders the patient clinically euvolemic. Your strict management mandate here is free water restriction. On the flip side, CSW is driven by the release of brain natriuretic peptide from the injured brain. This forces massive renal sodium and water loss, leaving the patient profoundly hypovolemic. The absolute management mandate for CSW is aggressive isotonic volume resuscitation.
Let's apply this. Day 3 post-subarachnoid hemorrhage. The patient develops a sodium of 124. They're showing severe tachycardia and dry mucous membranes, and their urine sodium is 55. How do we evaluate this presentation? Let's meticulously eliminate the distractors from our 5 choices. The presence of tachycardia and dry mucous membranes definitively isolates this as hypovolemic cerebral salt wasting, not euvolemic SIADH. Therefore, choice A, fluid restriction, is instantly fatal. You just cannot restrict fluids in a profoundly volume-depleted patient. Choice B, 3% hypertonic saline, is incorrect because the patient isn't actively seizing or comatose. Choice C, 5% dextrose in water, is a hypotonic solution, so it worsens the hyponatremia and is a terrible volume expander. Choice D, dimeclocycline, induces nephrogenic diabetes insipidus to target SIADH, which is simply the wrong disease process here. That leaves choice E as the absolute mandate. 0.9% normal saline resuscitation directly addresses the profound hypovolemia driving the CSW. All right, on to Module 3, polyuria and lithium kinetics. Evaluating hypernatremic polyuria, which we define as greater than 3 liters a day, requires a mandatory sequential diagnostic protocol. You must walk through these steps. First, confirm the polyuria and hypernatremia. Next, execute a water deprivation test. By withholding fluids, a normal response would be to concentrate the urine. If that urine remains inappropriately dilute, you've confirmed diabetes insipidus. Step 3 is localizing the pathology by administering exogenous ADH, which is desmopressin. This brings us to the desmopressin challenge. Desmopressin is our synthetic ADH analog. If you administer it and the urine osmolality drastically increases by more than 50%, you've diagnosed central DI, meaning it's a pituitary failure to produce the hormone. If you administer it and the urine osmolality remains low, the kidneys are inherently resistant to the hormone, which diagnoses nephrogenic DI. Now let's look at the pharmacological exception, lithium-induced nephrogenic DI. Lithium involves a really discrete molecular mechanism. It's unique because it directly enters the principal cells of the collecting duct via epithelial sodium channels, or ENaC. Once it gets inside, it mechanically interferes with the intracellular signaling required to insert aquaporin channels into the membrane. And without aquaporins, water simply cannot be reabsorbed, driving massive polyuria. So here is your high-yield absolute. When severe psychiatric instability mandates that a patient must remain on their lithium therapy, the exact specific antidote is amiloride. Amiloride acts by physically blocking that ENaC channel at the luminal membrane, completely preventing any further lithium from entering the collecting duct cells and halting the nephrotoxicity in its tracks. Let's tackle our final integrated assessment. We have a bipolar patient on long-term lithium therapy presenting with severe polyuria, exceeding 5 liters a day. Their lab work reveals a completely normal serum calcium level. What is the most precise pharmacological intervention required here? Let's break down all 5 choices definitively. Choice A, desmopressin, is totally ineffective here because the kidneys are already physically resistant to ADH due to the intracellular lithium. Choice B, hydrochlorothiazide, can paradoxically be used for generic nephrogenic DI by inducing mild hypovolemia, but it is not the specific antidote for a lithium driver. Choice C, calcitonin, targets hypercalcemia, but we've already established calcium is normal. Choice D, discontinuing lithium completely, introduces unacceptable risks for severe psychiatric decompensation. It's just not the first step when a targeted antidote exists. This definitively isolates choice E, amiloride, as the precise pharmacological intervention required to block ENaC and protect the collecting duct. We conclude this explainer with a definitive clinical absolute. The margin between stabilization and iatrogenic catastrophe is incredibly narrow. Survival in critical electrolyte management relies entirely on rigorous, methodical, physiological tracking over the temptation of rapid symptom reversal. Precision in recognizing discrete mechanisms, respecting established metabolic ceilings, and administering highly specific antidotes is the sole path to a perfect 270-plus level clinical execution.